One sec. All right, so good morning. This morning we're pleased to have Dr. Justin Jordan with us, who is director, I guess, of the Neurofibromatosis Center here at Mass General Hospital. We have a lot of patients in common, and I guess they have a lot of systemic treatments that are new, and we're looking forward to hearing more about. So Dr. Jordan, go ahead and you can begin your presentation.
Awesome. Well, thank you so much for the invitation to join you today. I'm going to open up my slideshow here. Let's see. Share my screen. Okay. I think you can see the full screen view. Is that right now?
Yep, we got it.
Okay, great. Well, thank you so much for the invitation to come talk with you all today. I'm really happy to be here. And as I was putting this together, I was thinking about what great opportunities we have among ourselves for collaboration, even moving forward beyond clinical care. So glad to go through some of this with you. So I do have a few disclosures, but none of these affect what we'll be talking about today. So I want to talk with you first about just reviewing peripheral nerve sheath tumors and the associated syndromes where we overlap in our clinical practices, and then we'll talk about some of the systemic therapies in each of those tumors and syndromes. The vast majority of what I'll talk about today is not FDA approved. So Selumetinib is an FDA approved drug for pediatric NF1 associated plexiform neurofibromas, but everything else we hear today is actually not FDA approved. So this is just a sort of general overview of the three primary diseases that where our practices intersect: neurofibromatosis 1, neurofibromatosis 2, and schwannomatosis. And for those people who don't see these diseases every day, sometimes they get a little blurry. So I like to show this table sort of from the beginning. NF1, the primary tumor, especially where our practices overlap, is neurofibromas, whereas NF2 and schwannomatosis are primarily schwannoma-driven diseases. But importantly, NF2 is largely a vestibular schwannoma disease, while schwannomatosis is non-vestibular schwannomas. There is a whole variety of additional tumors that can happen in each of these syndromes. We'll talk a little bit about those, as well as various other symptoms that patients may experience. So I'm going to start with NF1, which is certainly the most common of these. NF1 is an autosomal dominant disorder, but about 40% are first in family, so sporadic cases. There's no such thing as a carrier in this disease. So if you carry a pathogenic variant, then you certainly will show evidence of the disease. Incredibly common, 1 in 3,000 live births. And it's a very interesting genetic phenomenon in which there are so many cofactors with regard to other genes that modify the expression of the NF1 gene, and environmental factors that the genotype-phenotype correlation is essentially non-existent in this disease, with very few exceptions. You can see that the lifespan is actually pretty normal for these individuals, though. The diagnostic criteria for NF1 were actually just updated last year for the first time in 20 plus years. And primarily, there's a branching point. I won't belabor this, but the first branching point is whether somebody does or does not have a parent with NF1. So if you don't have a parent with NF1, you need 2 of the clinical signs. If you do have a parent with an NF1, you need 1 of the clinical signs. Importantly, this is the first iteration of diagnostic criteria for NF1 that includes genetic testing. So now a pathogenic NF1 variant would be 1 of 2 required diagnostic criteria for this disease. The NF1 signaling pathway is worth talking about because it plays a large role in some of the targeted therapies that we're looking at. So NF1 is what we call a RAS gap protein. So it is involved in regulation of RAS expression and activation of downstream cascades, including those in the RAC, RAF, and PI3 kinase pathways. And I will just highlight, because we'll talk a lot about it, that so included downstream here are RAF, MEK, and ERK. Which of course have a large role in some other diseases, including melanoma, for instance, but we'll talk about those in NF1. So In terms of pathogenic variants for NF1, which I'm sure you know, but by the way, pathogenic variant is the new preferred term over mutation, just because patients don't like to think of themselves as mutants, understandably. Among the spectrum of pathogenic variants in NF1, there have been over 3,000 individual pathogenic variants identified. And it's pretty fascinating. You can see that there's really no predominant type of pathogenic variant that we've identified. Many splice site, intragenic. We often will see intronic pathogenic variants in this disease. So it's a very complex genetic pathway. And as I said, there are a lot of complementary genes that impact the expression of the pathogenic protein that's translated for these, which limits our ability to do genotype-phenotype correlation. So the hallmark of neurofibromatosis type 1 is cutaneous. Neurofibromas, subcutaneous are closely related. So more than 95% of individuals in NF1 will have these tumors. And you can see a variety of types. We have some patients with a relatively mild burden of disease in terms of cutaneous neurofibromas, other people in whom there are so many cutaneous neurofibromas, it may look like there are tumors on top of tumors when you evaluate them in the clinic. And these are all primarily soft, non-painful. They may be sessile or pedunculated or a combination of the two. They can sometimes get superficial infection. They can get abscesses within the tumors, especially because they can be quite pruritic. And as patients itch them, they may introduce surface bacteria and suffer the consequences thereof. So we try to be very aggressive in treating the pruritus so that we don't have the secondary infections. We sometimes use topical or even oral antihistamines. Some of the neuropathic pain medicines can help, but the itching can be quite severe. And then pathologically, these are just a really big combination of cell types. So we certainly see spindle cells, but lots of perineural cells, fibroblast, mast cells. And specifically with regard to the mast cells, it really, first of all, the correlation between a heavy mast cell presence in a tumor and the fact that they're pruritic can't be overlooked. And in fact, there's a lot of theory that the itchier the tumor and maybe even activating mast cells by itching the tumors may introduce a cycle of tumor growth as the mast cells expand. So beyond cutaneous neurofibromas, plexiform neurofibromas are an incredibly common cause of morbidity in NF1. These are pathologically benign, although in clinical practice, they may carry a lot of challenges for patients. They're present in roughly half of people with NF1. And we actually think that probably you're born with all of the plexiform neurofibromas that you'll have in your life. Although they may not grow until a little bit later and therefore may not be actually identified until later in life. By definition, they involve multiple nerve fascicles, each surrounded by perineurum. And generally, we see these in large nerves or within the brachial plexus or lumbosacral plexus, for instance, although we can certainly see them anyplace. You can see a couple examples here of patients. This is an individual with a large plexiform neurofibroma in the neck involving, you can see many of the individual nerve bundles. And this is somebody with a large cutaneous, at least plexiform neurofibroma in the thigh. And sometimes the extent of how these tumors impact the leg in this instance can be challenging to discern clinically from only an external view. So MRIs turn out to be very important in looking at these. I think it goes without saying to this group, but complete resection is often not possible just because of the adjacent vascular structures, adjacent organs in some case, the fact that there are multiple nerves involved, which may impact neurologic deficit as a result of the surgery. And so whereas we rely so heavily on our surgeons for many of the manifestations of NF1 and the other diseases we'll talk about, plexiform neurofibromas really have turned into a delicate partnership, I would say, between surgery and alternatives. And we'll talk about those alternatives in a minute. I wanted to run through the full spectrum of the tumors that we think about first. So for those of you who are looking at MRI reports, especially for patients with NF1, you may be coming across this terminology with increasing frequency, and I think it's worth pointing out. So distinct nodular lesions were identified or were pointed out from the NCI group a couple years ago. And basically, they determined that within a subpopulation of patients with NF1, there are some lesions that are, as they define, well demarcated, encapsulated, appearing more than 3 centimeters, lacking the central dot sign, and present either within or not a plexiform neurofibroma. And based on their natural history data, they suggest that there may be a faster growth rate for these distinct nodular lesions, up to 2 times faster per year compared to plexiform neurofibromas without DNLs. And so there's been a lot of discussion in the NF1 literature, just thinking about should we be screening for DNLs routinely? Should we increase the frequency of scans in these individuals and so forth? Data from an MGH older adult cohort suggests that maybe that growth is not quite as robust in adults. There may even be spontaneous shrinkage in some cases. We know that the populations represented at the NCI versus MGH and maybe even the community are heterogeneous or different from each other, that is to say. And so I think that there remains a really large opportunity for study of DNLs and growth patterns and whether there's any underlying risk, not only truly of growth, but even of malignant potential. So related to that fiber, this newly recognized entity, atypical Neurofibromatous neoplasm of uncertain biologic potential, ANNUBP, as we call it in clinic. This is actually now in the WHO diagnostic manual, but it is only used for patients with NF1. It's not identified in individuals without NF1 underlying. And so this, as the title implies, may have a higher likelihood of malignant transformation down the line. Pathologically, there's atypia, there's hypercellularity, loss of architecture, increased mitoses. And based on a few recent publications, there's a strong association with CDKN2A 1 and 2 loss. And in looking at a couple natural history studies that are coming out here recently, it looks like from a benign plexiform neurofibroma to malignant peripheral nerve sheath tumor, CDKN2A loss or CDKN2B loss is one important step in the transition from benign to malignant. And those are a hallmark of these ANNUBPs. So with increasing frequency, we're identifying these in our clinical practice and really having a lot of discussion about how do we adjust our approach to treatment, perhaps more aggressive surgery to even a second surgery to go back and remove additional tumor if possible to try to reduce the long-term risk of malignant transformation and so forth.
Justin, how are you identifying those? By PET scan?
Yeah, so the PET scan is always challenging in NF1. It's a great question. Neurofibromas are often PET avid, completely benign neurofibromas. And so I would say that ANNUBP and MPNST appear to largely be arising from within a benign plexiform neurofibroma. A single cell develops a pathogenic variant and has clonal expansion. And so often what we'll identify is an island of intense FDG avidity in a greater sea of mild to moderate FDG avidity. So it's not straightforward at all. There's also some question as to the overlap between these ANNUBPs and the distinct nodular lesions that I just talked about, where maybe some of those distinct nodular lesions are actually the MRI indication of a higher likelihood of transformation, so may represent ANNUBP. Importantly, although ANNUBP, one of the histologic characterization is the atypia, it's important not to mix up these with neurofibroma with atypia, which is another histologic diagnosis that's completely benign. It's just the other way that we call that is ancient neurofibromas, and those are completely benign findings.
So are you looking based on symptoms entirely, or do you do periodic screenings with PETs, or what is your approach to making sure you identify these?
Right now, purely based on symptoms.
Okay.
I'll show you in a couple of slides whole body MRI scans, which we're using in a research context currently. One question would be, as we begin to differentiate tumor types and tumor risks, should we be incorporating regional or whole body MRI scans more routinely? I would say that now the majority of us in the field are following individuals clinically. And when there is identification of tumor growth or new neurologic deficit or pain in a particular region, then we may begin to investigate in a reactive fashion. And I think you're getting at, should we be thinking about proactive approaches as we make these differentiations? I think there's certainly an opportunity there. The challenge is scale. Not only because of the enormous number of patients, and within each patient, the enormous number of tumors, and then the risk of unnecessary biopsy, for instance, for potentially non-malignant or non-problematic tumors. So I think that there's a lot that we still need to suss out in terms of understanding the biology of these and figure out if it's actually worth aggressive approaches to these tumors, depending on their natural history. They've only been recently sort of pointed out. The last tumor that I'll sort of point out in this spectrum is malignant peripheral nerve sheath tumors. In NF1, the lifetime risk is between 8 and 13%, and this is the leading cause of mortality in NF1. As I pointed out for ANNUBP, this is generally a clonal expansion of a particular cell in a plexiform neurofibroma, and so that can complicate the diagnosis. This is the patient that I share with Dr. Williams, who had an MPNST in the right brachial plexus. And you can see that there was some increased FDG avidity in sort of the superficial and in the lower part of the tumor here within a relatively increased FDG avidity of the tumor. And so for this, we did a targeted biopsy of one of the FDG avid foci and identified MPNST in that tumor, which is of course important for surgical planning because on-block resection is a requirement for MPNST. Genetically, as I mentioned, there's this spectrum, not only histologically from benign plexiform neurofibromas to the malignant peripheral nerve sheath tumors, but we also see this spectrum of genetic changes. So there was the CDKN2A or N2B loss in the ANNUBPs, and then as we move into MPNSTs, these will all have CDKN2A or B loss, and they will additionally have SUS12 or EED mutations in the tumors. And there's a lot of evaluation happening now, looking at how do we utilize that information for targeted therapy purposes. It seems that as is the case with many histologies, once you go into this malignant aspect, sometimes just a pure targeted, going for a single mutation is not going to be sufficient, just given the aggressive nature of the genetic changes. So we do use whole body MRI scans in clinical practice. I would say that 90% of them are in research right now. And that relates to, first of all, payers often will not pay for whole body MRI scans in NF1. But secondly, as I pointed out, often clinical practice either may not be impacted by the whole body MRI scan, or if it is, we introduce the risk of unnecessary interventions or biopsies and so forth. I think that For the patients in whom we've done it on a non-research basis, evaluating the underlying burden of internal tumor is important, not only for discerning neurologic examination findings, and for pre-planning. If a patient calls me, the catchment area in our practice is very large. So a patient calls me from Tennessee and says, I've got some new numbness in my right thigh. Well, here's that patient, and I don't think that there's a huge, sort of challenge understanding where that might be arising from, and it can help us sort of target our evaluations. One of the classic challenges in NF is the localization of neurologic deficits, wherein without any preconceived evaluation here, you could imagine that somebody might get imaging of their lumbar spine and their sacrum and pelvis and upper thigh if they called with sort of numbness in that distribution, whereas at least here we have something to go on based on the baseline evaluation. There's also increased risk of MPNST with larger internal plexiform neurofibroma burden, and so evaluating a patient's risk for prognosis is helpful for clinical planning. So plexiform neurofibroma natural history is still not entirely clear. The largest study published so far has been from the NCI, and they've looked at children and young adults. And you can see that there's an inverse correlation. The younger the individual with NF1, the more plexiform neurofibroma growth they had. The older they got, the sort of slower they went. And in our series, which has been presented in conferences, not yet published, there may even be sort of less growth in adults, maybe even spontaneous shrinkage in many cases. So looking across the lifespan, it's important to understand this trajectory as we think about who needs treatment, as we think about clinical trial endpoints. If a tumor shrinks, was it because it was going to anyway, or because the drug actually worked? So this is a pretty eye-opening understanding of these tumors, especially as we begin to see the spontaneous regression. Now, plexiform neurofibroma is certainly the most morbid tumor in NF1, and so I think I'll focus the rest of my time in the NF1 landscape talking about those. In terms of treatment, surgery is common, but often is limited, as I mentioned, by vital structures, by vascularity, by the involved nerves. And so complete resection is very often not possible. Radiation has not been considered as a primary treatment modality because we're talking about a tumor predisposition syndrome anyway. And so we worry about secondary malignancies. There's an underlying risk of vasculopathy in NF1 that we may complicate by introduction of radiation. And then in terms of chemotherapy, there hasn't been a whole lot of evaluation of cytotoxic chemotherapies for these tumors. They're not malignant. And so we wouldn't have a high suspicion that cytotoxic chemotherapies would work. Also is unattractive based on the fact that often these chemos are carcinogenic or mutagenic. These patients also are not apt to die anytime soon from these tumors. And so introducing side effect laden toxic chemotherapy for a benign tumor that's not deadly is sort of a challenge to consider. So this has really been an area ripe for evaluation and targeted therapies. And as I'm sure, yes.
Find that the plexiform lesions are as symptomatic as the simple lesions? Are they equally as symptomatic, or is there a difference?
Yeah, it's a great question. So plexiform neurofibromas largely grow in childhood. Yeah. And I would say that if you make it to adulthood without symptoms of plexiform neurofibroma, then it's likely most people probably won't get many major symptoms. For those individuals who arrive at adulthood with symptoms of their plexiform neurofibroma, very often those can worsen. There is a subset. It's not entirely clear how small. There's a subset of patients who have plexiform neurofibroma growth in adulthood and can develop morbidity. And certainly we're now treating those more aggressively since we have targeted options we'll talk about here. In terms of the discrete neurofibromas, I think that there's a good chance those are actually more symptomatic. There's not sort of data on this, but those probably grow with increased frequency in adulthood, I would say, and so may end up causing more symptoms than the plexiforms for the average adult. So Selumetinib is a MEK inhibitor. I showed you that the RAS-MEK-ERK pathway is largely impacted by the NF1 pathogenic variants. So these are images from the phase 1 clinical trial of Selumetinib for plexiform neurofibromas in children. And they looked across 3 different dosing, and across all 3 of those, the median improvement in tumor volume was 70%. They calculated at least a 20% shrinkage as a success, which is sort of the standard that we use in volumetric analyses of these tumors. So 70% of patients had significant tumor shrinkage. You can see one of the representative images here. Based on this, they went on to do a phase 2 that was published in 2020 in the New England Journal, where they again showed 70% response across a second population of individuals. This is one representative child who had a neck plexiform that you can see grossly reduced in size. And this is a plot of his pre-treatment and post-treatment tumor volume with Selumetinib. This is data out of the NCI, and I told you already that they're the ones who have published the largest natural history study to date. So in their paper, they plotted natural history from the previous study compared to Selumetinib data and showed a pretty remarkable Kaplan-Meier curve. So based on this, in April of 2020, the FDA did approve Selumetinib as the very first therapy in NF1. It is approved for pediatric patients 2 to 18 with plexiform neurofibromas that are either symptomatic or inoperable.
Can I ask you on that, when you achieve that reduction in size, when you stop the medication, does it grow once again, or do you have to?
It does.
Okay, so you need to keep them on a chronic suppression sort of therapy, is that right?
That is the current thinking. One of the major questions that we're asking is, is there an upper limit to that? Maybe you have to keep them on for 2 years or 3 years and then you can stop. But I don't have any figures of that here, but there is at least one figure in their publication where somebody developed dose-limiting toxicity. They stopped the drug, the tumor grew again, they started the drug again, the tumor shrank again. So at least based on the data that we have available, it's likely that tumor will grow again after we stop the targeted therapy.
Got
it. Which I think points out the enormous importance of tolerability of any treatment we use in these tumors. As I sort of alluded to, they're non-malignant already, and they may have to be very long, long use. So following Selumetinib's approval, there are a few other MEK inhibitors that are in evaluation right now. So Mirdametinib has been studied in the Neurofibromatosis Clinical Trials Consortium, which is a DoD-funded consortium for people 16 and older. And they found a 42% partial response rate in their group, so slightly less than the 70% Selumetinib showed. The adverse events were similar in this population. Well, I should say they're actually a little bit different. In pediatric patients treated with MEK inhibitors, rash tends to be less of a problem, although that is a prominent feature that has been shown in adult MEK inhibitor trials. Binimetinib is another drug that has been studied here recently, published in abstract form only so far. This trial importantly had 2 strata, one for kids, one for adults. And they looked at 12 months of treatment looking for response. And they showed close to 70%. The adult, they started with 45 milligrams as their treatment dose and then actually reduced to 30. whereas in pediatrics, they stayed at a constant dose, but close to 70% in both of these strata for Binimetinib. So I would say between these two, it looks like MEK inhibitor has a class effect for the opportunity for shrinking plexiform neurofibromas in NF1, probably both in adults and pediatrics. Although the differential benefit of one drug versus the other remains under evaluation through these multiple different trials. I also just wanted to point out that this is a case of mine. Based on all of this data coming out for plexiform neurofibromas, I would say many in the field are using MEK inhibitors for other symptoms of NF1. So this is a patient of mine who had an optic pathway glioma that developed and grew to be pretty nasty in her late 30s. And we used Selumetinib, still are using Selumetinib, but after 6 months, she had all of this enhancing disease basically went away. You can see from her visual field testing, she regained visual vision in the right lateral or the right temporal field. And then her vision improved from 2100 to 2025. So pretty remarkable clinical and radiographic change using MEK inhibitor in at least in the optic pathway gliomas of NF1, but also probably in other of the manifestation. Now, the obvious question is, does it help with peripheral neurofibromas, the small discrete tumors? And actually, that remains to be seen. It is under evaluation, but we don't yet have data for that piece. The last thing that I'll say in the NF1 sphere is just that there are topical therapies under evaluation for the cutaneous neurofibromas. I'm sure many here are familiar with electrodesiccation. There's not a whole lot of prospective data on electrodesiccation. Some patients love it. Some patients don't think that it's worth it. I think that we have at least one physician at MGH who does it occasionally, but we don't have an enormous practice here, to my knowledge. As you can see from the photos here, tumors may become less obvious, but they don't completely disappear. And sometimes there's scar tissue that replaces the tumor when you have the treatment. There's an ongoing study of a topical MEK inhibitor through a company called Inflection that is running at a few sites now, hopefully going to open at MGH as well, which will, in an ideal world, reduce some of the systemic toxicity of MEK inhibitors and allow us to have maybe even greater concentration for some of the skin tumors. And then there's another study ongoing at MGH currently where we're looking at device-based treatment for cutaneous neurofibromas using one of 4 different types of treatment. So either Kybella injection, which is an injection that's FDA approved for double chins, or 2 separate lasers at different wavelengths, or radiofrequency ablation.
Has anyone looked at using the MEK inhibitors, like directly injecting them into the plexiform neurofibromas?
To my knowledge, there's not data for injection of MEK inhibitors. Okay, so I'm going to move from NF1 to NF2. So NF2 is also an autosomal dominant disorder. The name is a misnomer. There are no neurofibromas associated with NF2, and in fact, it will be renamed soon. There is a manuscript pending that will change the entire diagnostic landscape of NF2 and rename it altogether so that we can lose the overlap here. So it's autosomal dominant inheritance, but about 50% are first in family again. So there's a high rate of spontaneous pathogenic variants. And we see an enormous amount of mosaicism in this group. And so for those of you who don't think about genetics often, that means that after the zygote is formed and somebody's in sort of blastocyst stage or later, a spontaneous pathogenic variant occurs in one cell. There's clonal expansion of that cell as the entire fetus grows. And so the full-formed individual will be heterozygous, where some of the cells will have wild type and some of the cells will have pathogenic variants in the underlying disease. And the reason that's important is it makes diagnosis much more challenging because individuals may present later in life. They may present with not classical features. And as we'll talk about schwannomatosis here in a minute, the clinical overlap between schwannomatosis and NF2 just grows more and more complex as we have additional genetic capabilities to sort these things out. We thought we knew more than we actually did, I would say. NF2 is also 100% penetrant. The incidence is about 1 in 25,000, so much rarer than NF1. And different from NF1, clinical symptoms tend to look similar through families. So the hallmark symptoms of NF2, there are a lot of eye findings. So there's juvenile cataracts and epiretinal membranes that can be present from very early on. Intracranially, vestibular schwannomas are by far the most common tumors that we see. Non-vestibular schwannomas can occur intracranially as well as peripherally, and then meningiomas. Through the spine, we see lots of schwannomas and meningiomas, as well as ependymomas in about half of people with NF2. And then peripherally, a good number of schwannomas and a large overlap of peripheral neuropathy, which can complicate the neurologic evaluation. So the most common presentation is presenting in early 20s with bilateral vestibular schwannomas. So people generally come in with hearing loss, tinnitus, dizziness. The diagnostic criteria are actively, they'll be changed here within the next few months, hopefully, but by and large, if you see somebody with bilateral vestibular schwannomas, they probably have NF2. If you see somebody with a unilateral vestibular schwannoma and some other sort of combination of meningioma, ependymoma, then they may or may not have NF2 or schwannomatosis. The new diagnostic criteria will rely quite heavily on genetic testing of tumors and germline for individuals, or unaffected tissue, I should say.
Because some folks switch to that already. Because I feel like I've had a number of patients in the last couple of years who have no vestibular schwannomas who are coming to clinic and telling me that they've been diagnosed with NF2.
Yeah, it's a great point. Yes, probably. I would say that anybody who is, yes, many of us are using genetics to make these diagnoses. If you can confirm a common pathogenic variant as the first hit in 2 tumors, and that may or may not be present in the germline, then somebody does have a pathogenic NF2 variant causing a tumor predisposition syndrome. Incorporating that into the diagnostic criteria is iterative, I should say, but the international consensus group is coming together to account for that soon. So NF2 biology is a little bit different. NF2 is involved in controlling cell density, cell size, and growth rate. And so there's been a lot of great publications, including out of Vijay Ramesh's lab at MGH, in blocking NF2, where cells get bigger, cells get more dense, cells have increased turnover. And so there are lots of opportunities for targeted downstream treatments for NF2 mutant tumors. Different from NF1, NF2 actually has a pretty decent overlap in terms of genotype-phenotype correlation. And in fact, it published a few years ago from some colleagues in the UK, there's now a genetic severity scoring system that we're able to use in clinic that turns out to be helpful in prognosticating. And so looking at the type of pathogenic variant and the location in which exon, we can classify as a mild, moderate, or severe pathogenic variant. And I didn't show you all the tables here, but that will help us understand age at diagnosis, age at first surgery, number of major surgeries in the lifetime, age at death on average. And so we will utilize this genetic severity scoring to help patients understand, what to expect and to help us guide a little bit in terms of treatment decisions. So schwannomas are certainly the most common tumor in NF2. However, the vast majority of these are vestibular schwannomas. They are, it's interesting, when you look across the board, schwannomas are primarily sporadic tumors that have nothing to do with NF2. And I always have to remind myself, I see many patients as a consult who have been identified with a single schwannoma. And I think I should see many of those people to help figure out if that's form fruit of a disease. But it's always important for me to remind myself that more than 90% of schwannomas are completely sporadic. However, within NF2, schwannomas are sort of a primary tumor that we focus on. They may present intracranially, paraspinal, peripheral nerves. Merlin loss, actually at a time, there was a publication that showed that Merlin was absent. Merlin, of course, is the protein product of NF2. Merlin was absent from 100% of schwannomas. A more updated figure from Dr. Stemirohamimov shows probably closer to 50 to 75% of sporadic schwannomas are Merlin deficient. And of course, all NF2 associated schwannomas are Merlin deficient. Pathologically, schwannomas are well encapsulated. For people who are taking board exams, they always have the concept of this Antoni A and Antoni B foci. The Antoni A are much more compact and have Verrier bodies, and the Antoni B are more loosely arranged spindle cells. Peripheral schwannomas in NF2 are a challenge that unfortunately often gets overshadowed by other tumor types. And so as I was putting this talk together, I was thinking, what a great opportunity we have for collaborative work together in this realm, because peripheral schwannomas in NF2 are very common. They just get overlooked in many cases. So surgery remains the primary treatment modality for peripheral schwannomas. And these can be significant, multifocal. As you can see, these are a couple of my own patients with peripheral schwannomas and spine and peripheral schwannomas. And you can imagine how incredibly morbid some of these can be. The challenge to when we think about using targeted therapies and studying on clinical trials, I sort of was thinking about multiple challenges for using peripheral schwannomas as a clinical trial endpoint. First of all, they're often not the most pressing tumor for patients, fortunately or not. And so many of the trials are written for the vestibular schwannomas or meningiomas, which may have a higher risk of mortality. The classical trial design that we use in chemotherapy and in the cancer world chooses a target tumor. And if that target tumor responds, then you stay on the drug. If it doesn't respond, or if the tumor grows, then you come off. But it turns out to be pretty challenging in somebody who has hundreds or thousands of tumors to choose the target tumor ahead of time, and to follow, first of all, to follow the one target tumor longitudinally, but also if you choose one and it happens to be the only one that isn't responding, for instance, the patient comes off study. So there's a lot of challenges with this. And the last thing is sort of just reliable measurement considerations. Some of these peripheral schwannomas can be particularly small. They can be in a field of schwannomas. And so making sure that you're measuring the same one, that you have high enough resolution for accurate measurements, whether those be volumetric or linear, I think are important considerations that still need to be ferreted out. We do use whole body MRI and NF2 primarily in terms of research as well. We're wrapping up a study now where we acquired whole body MRI scans on a cohort of individuals with NF2 and schwannomatosis about 10 years ago. And we're now doing a second whole body MRI on as many of those patients as possible to look at natural history for those individuals. And in that group, this has been presented in abstract fashion so far, in that group, the majority of NF2 associated schwannomas did grow over time despite systemic therapy. So that's different from NF1, where there was a large proportion of spontaneous shrinkage. You can see one representative patient in whom a schwannoma in the arm grew significantly by 1,130% over the course of the decade. And this is just one of the many patients on the study where you can sort of see the multiple schwannomas that are present here. Whole body MRI is a useful tool for sort of counting schwannomas, volumetric analysis. It does not have sufficient resolution to visualize brain or spine well. And so we don't use it to replace brain or spine, because in order to get the entire body in a relatively short time frame, we have abbreviated the acquisition to coronals only, no contrast, and the slice thickness, I'm going to say, is a ½ centimeter, if I remember correctly. So a lot of possibility of losing some of those smaller tumors, both in the body, but certainly in the brain and spine.
You all use ultrasound at all for following these things? I guess the next slide shows that.
Yeah. So this slide is from a photo from a paper. We don't use ultrasound currently,
Okay.
and as I was sort of thinking about this, it's an interesting question whether there's an opportunity for ultrasound here. Here, I just wanted to point out this concept that I think is relatively unique in the NF2 literature called tumorlets, which really, I think the term was coined at MGH. Basically, if you think about the entire length of a nerve and its Schwann cells in the nerve sheath, every one of those carries a first hit in the pathogenic NF2 variant. And the likelihood of a second hit turns out to be quite high, as evidenced by the large number of tumors you've seen in some of these scans. So people can have just enormous numbers of teeny tiny tumors that are just 3 cells in size sometimes, all along the expanse of a nerve. And so I point this out for a few reasons. First of all, when we count up tumors, we're probably severely undercounting, because there are probably many more of these tumorlets that are present and just not grossly visible. We can, to your point, we can use ultrasound in some cases to visualize these tumorlets. And so, when a patient presents with a new neurologic symptom, albeit mild, probably for some of these things, we may not visualize some of the very smallest tumors on MRI, for instance, but maybe ultrasound may be helpful in a case like that. And so when we think about people who have normal imaging with neurologic deficits, we might think about tumorlets. The other thing is when a schwannoma is completely removed and then there's recurrence, quote unquote, it's not impossible to, it's just as likely probably that the Schwann cell right next door or 2 doors down was a burgeoning tumorlet that has become a new tumor. And so rather than true recurrence, it may be a de novo tumor in a similar location, just based on the equal risk across all of those Schwann cells. So unfortunately, that's about the extent of what's happening in peripheral schwannomas in NF2. So I wanted to talk to you a little bit about just what's happening in the rest of NF2, in case that might be helpful in terms of treatment consideration. So, and I recognize we've got 10 minutes left. Vestibular schwannomas are by far the most common NF2 associated manifestation. And the thing that we spend the most time talking about, surveillance is actually our preferred method of following these for right now, because of the risk of morbidity with the treatments we have available. Surgery remains a very common tool used for resecting vestibular schwannomas with a risk of hearing loss, sometimes facial weakness. And just as I pointed out with the tumorlets, people may get recurrent vestibular schwannoma on the same side, even if you remove one. And perhaps it's from, actually, those have been studied genetically to have different second hits in many cases. So they are truly a de novo tumor. So surgery leaves a little something to be desired, although for some patients, but still a very helpful tool. Radiotherapy does hasten hearing loss in a given ear and carries a risk of secondary malignancy. These schwannomas can become MPNSTs after radiation, and whereas people are so young when they're diagnosed with NF2, 22 years on average, we try to avoid radiation if possible. So chemotherapy has taken sort of a front row seat in terms of the treatment here. Bevacizumab, although not FDA approved, is by far the most commonly used treatment for vestibular schwannomas. About half of vestibular schwannomas may reduce in size with the treatment of bevacizumab. Interestingly, despite searches for biomarkers, we've not found a great way to predict who will and will not respond to bevacizumab. And also, bevacizumab may improve hearing related to vestibular schwannoma in close to half of patients. The size of a vestibular schwannoma actually has no correlation with hearing in the same ear. So some patients may have improvement in size but not hearing, or hearing but not size. And similarly, we haven't yet figured out a good way to predict who will respond to bevacizumab in terms of hearing. But certainly this remains the backbone of our NF2 practice for vestibular schwannoma treatment. And we have a good number of people that we have treated long-term for many years with bevacizumab. But similar to the MEK inhibitor story, when we stop the treatment, the tumors often regrow, the hearing often worsens, and so we have to put patients back on as much as possible. There have been a handful of sort of recent targeted trials for vestibular schwannomas. So everolimus is a TORC1 inhibitor that stabilizes vestibular schwannomas, which can be helpful in many patients, but certainly I think shrinkage would be better. Lepatinib has also been evaluated for these, and there was a 23% volumetric response, 70% of tumors stable at 12 months. So perhaps early signal in a couple of these other targeted therapies, but no home runs by any means. Meningioma also turns out to be an incredibly common cause of morbidity in NF2. So 80% of people with NF2 will have a meningioma. And you can see that they can be widespread, as in the spine here, and these multiple intracranial meningiomas. They can also be pretty infiltrative, especially in skull-based tumors. So these are another common issue that we're looking for treatments for. In terms of targeted therapy evaluation in meningioma, those same two, so lepatinib in a secondary analysis probably stabilizes meningiomas while on treatment. And a combination of everolimus and bevacizumab has been looked at for sporadic meningioma, but was able to stabilize growing tumors in 88% of cases. So although, again, not exactly what we're shooting for in terms of tumor shrinkage, these may be good for, maybe quite helpful for patients who have growing tumors that otherwise have no treatment available. We performed a study of vestusertib, which is a dual TORC1, TORC2 inhibitor, and treated 18 patients. We had one patient whose tumor shrank, and the remainder, 89%, had stable disease at 6 months. So again, not a home run. There is a clinical trial going on, and I think that this is actually potentially very important for you all. This is the first study of its kind for NF2 where it's a basket trial. So there's a basket for each of the NF2 associated tumor types, including non-vestibular schwannomas. And then it's also a platform trial. So there are multiple drugs coming online. Brigatinib just opened up to a second phase, and then the second drug has actually just been named as in contract negotiations currently. In the brigatinib sub-study, the way the trial is designed is a cohort of individuals is treated in each of these 4 strata. They're followed for 6 months to see what their response is. And then the 2 best performing arms reopen for additional patients. And so we've just opened non-vestibular schwannoma and meningioma for a second cohort of individuals. So there may be something to be learned for peripheral schwannomas among this cohort. I'm going to scoot ahead. We're right at the end. I was just going to tell you briefly about schwannomatosis, which is a little bit different in terms of our thinking, because it's largely a disease of peripheral nerves where we have very little data on how to treat them. So we see that 90% of people have greater than 1 peripheral nerve schwannoma with schwannomatosis. There's also a large proportion with spinal schwannomas, subcutaneous schwannomas, and relatively few intracranial tumors. Pain turns out to be an incredibly common source of morbidity in this disease, which is, I would say, is different from the NF2 population. So 80% of people have chronic pain with an average intensity of 5 out of 10. Many people are taking multiple pain medicines without any clear indication of a good improvement in pain.
And there's no correlation of pain with size of lesion, is that right?
There's not. So we look, this is a paper I published a couple years ago where, first of all, there was a correlation with genotype and pain. So we looked at patients who had LZTR1 versus SMARCB1 mutations, and there was a significant difference in pain between those 2. We also looked at total body tumor number and tumor burden, and people with increased total body tumor volume had worse pain, but an individual tumor's volume has not been correlated with pain necessarily. Surgery is helpful sometimes for the pain. It's a little interesting. This is out of one series where 39% of surgeries performed in order to alleviate pain did so, but 75% of them actually went on to have pain recurrence, even potentially without the tumor recurring.
And is that in the same location or a different location?
Yeah, same location.
Same location, okay.
Yeah. For patients who had spine surgery, 45% had persistent deficits even after removing the target lesion on the spine surgery, and 27% had persistent postoperative deficits after peripheral surgery. Not to say that the surgery caused the deficit, but the deficit wasn't improved by removing the schwannoma. Okay. So surgery for peripheral schwannomas and schwannomatosis can be helpful, but it's a little hard to choose who's the right person to remove, because you may not alleviate the pain permanently or fix the problem permanently. This is another series looking specifically at spine surgeries. Gross total resection was possible in 92% of patients, and about half of them had recovery. 35% had improvement of some sort, but a small percent had stable or worsening disease. So probably the majority of people had recovery of their issue in this population after a spine surgery. We've looked at bevacizumab in this population and had temporary pain improvement in some, but never any tremendous or long-term pain improvement. And we do have one ongoing clinical trial using a nerve growth factor antibody called tanezumab, where we're doing a randomized delayed start. So you get randomized to either a dose of placebo or a dose of tanezumab for your first injection, and then everybody gets a dose of tanezumab for the second injection. And we're looking at overall pain and location of pain and so forth with this clinical trial. I know I'm right at the hour, and that wraps up what I had put together. I'm sorry for going right to 9, but I'm happy to answer questions if you all have time.
No, perfect. That was great. Thank you very much.
Yeah, absolutely. So NF1, lots of great treatment options in terms of chemotherapy. Schwannomatosis and NF2, still very much a surgical disease, and lots of possibility, I would say, for us to work together and find some new creative treatments.
Perfect. Thank you so much. I unfortunately do have to run to clinic, but that was exactly what we're looking for. I appreciate your time.
Perfect. Thanks a lot for the invitation.
You bet. Thank you.